Hello and welcome everyone to tonight's webinar, the sixth in the series on cardiac care in the ACT. This webinar covers evolving management of hyperlipidemia and also new thoughts on valvular heart disease. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kunal Mohiti, the Events Lead at Capital Health Network, and of course our expert speakers, cardiologist Dr. Liam Guiney and Dr. Peter Scott. First, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So all participants have been muted, so you won't be able to directly interact with the presenters, but please type your questions into the Q&A section of the Zoom box, not the chat section. And Dr. Guiney and Dr. Scott are happy to answer questions after they've finished their presentations. And also please feel free to self-report 1.5 hours of educational activities to your CPD home. Also, a flag for the free resource in the ACT and in other regions. Ours is called ACT Health Pathways, and it has pages on hyperlipidemia, statin intolerance, familial hypercholesterolemia, and heart murmurs. So as you all know, the Health Pathways login is now personalized, so please register for that. And every time you use Health Pathways, you can log it as a CPD activity. So on to our speakers. Our first speaker is Dr. Liam Guiney. Dr. Guiney is a structural and coronary interventional cardiologist practicing at the Canberra Hospital and at the National Capital Private Hospital. He is an expert in the management of valvular heart disease and performs procedures including transcatheter aortic valve intervention and mitral transcatheter edge-to-edge repair. So that's called TEER. His interests include complex coronary revascularization techniques such as calcium modification and CTO-PCI, which I'm sure he'll explain. Originally from Sydney, where he trained at the Prince of Wales Hospital, Dr. Guiney then completed fellowships in complex coronary intervention and structural heart interventions at both King's College Hospital in London and the Alfred Hospital in Melbourne. And I'll also introduce our second speaker as well, and that's Dr. Peter Scott. And some of you may be familiar with Dr. Peter Scott. He's been in Canberra for a while. He's a highly experienced interventional cardiology consultant and director of cardiology at the Canberra Hospital, as well as former director of cardiology at the North Canberra Hospital. Dr. Scott brings extensive experience in cardiac catheterizations and advanced cardiac procedures. He provides cardiac care and performs diagnostic cardiac tests at Core Cardiology and interventional procedures, angiograms and stenting at the Canberra Hospital and National Capital Private Hospital and Calvary Bruce Private Hospital. In 2019, Dr. Scott established Core Cardiology at Macquarie. This practice has grown rapidly in response to Canberra's need for comprehensive cardiac care. Under Dr. Scott's leadership, Core Cardiology has developed into a complete cardiac care centre, bringing together leading specialists and investing in advanced cardiac equipment. So thank you very much to both of them for presenting to us tonight. And I'll hand over to our first speaker, Dr. Liam Guiney, now. Thanks very much.
Hi, everyone. Thanks, Leonie, for that introduction. I'm just going to start by sharing my screen and just let me know if there's any issues there. All right. So look, I'm a structural cardiologist and interventionalist at Canberra Hospital, and I also work with Peter at Core Cardiology and see patients at the National Capital Private Hospital. And I want to talk to you a little bit about what's going on in the field of valvular heart disease at these sites, and with a focus on the new devices in transcatheter heart valve intervention and how they can help your patients. So we're going to focus on three of the main players in valvular heart disease, so aortic stenosis, mitral regurgitation, and tricuspid regurgitation. And just to give you a quick overview on, on the etiology of these conditions, as you know, aortic stenosis in adults generally comes in two primary forms. We've got degenerative calcific aortic stenosis and the congenital bicuspid aortic stenosis. They all follow the same common final pathway of fibrocalcific degeneration of the valve, but present at different age groups, with bicuspid valve disease presenting earlier in patients generally over 50, whereas the degenerative form is generally seen in patients over the age of 70. We do still see rheumatic aortic valve disease in Australia, but it's obviously significantly rarer, but that can also be a cause. Mitral regurgitation comes in two general forms. We term them either degenerative or primary mitral regurgitation, which is caused by a specific problem with the leaflets themselves or the subvalvular apparatus, such as flail or perforation in the context of endocarditis. And this is the most common cause of mitral regurgitation that is treated currently. Functional or secondary mitral regurgitation. In this context, the leaflets themselves are normal, but there is an issue with coaptation, either due to atrial dilatation and atrial functional MR caused by conditions such as atrial fibrillation or heart failure with preserved ejection fraction, where it's the annulus that dilates, resulting in a lack of coaptation reserve and valvular regurgitation, or ventricular functional MR, where the ventricle is dilated and the leaflets are tethered and pulled towards the ventricle, causing an issue with coaptation and thus regurgitation. Similarly, tricuspid regurgitation is also caused by primary or secondary forms, but in this case, TR is predominantly, almost 90% of cases, secondary, either to left heart disease causing pulmonary hypertension and right heart dysfunction, or like with mitral regurgitation, there's the atrial functional phenotype, which is due to atrial fibrillation and is a very frequent cause. The tricuspid annulus is quite a complex structure and is inherently different to the mitral annulus. With generally 3 leaflets, the annulus dilates in the anterior-posterior direction, and more TR begets more TR as the very thin-walled RV dilates greatly. And it's been recently recognized that we need to expand our grading criteria. So you may start to see echo reports expanding that in respect to tricuspid regurgitation. So you're used to seeing mild, moderate, severe, but in TR, we now recognize forms of massive and torrential, and there are quantitative measures that are required to meet this criteria. So it's not just the cardiologist getting a bit too excited about how much regurgitation there is. But these do have significant clinical implications. And this is all very relevant because this is a common problem. We see valvular heart disease, especially in our aging population, becoming more and more common. You can see some incidence rates there in patients over 70. And when we look at the Australian context, it's estimated that in 2021, there was approximately 600,000 patients with valvular heart disease. By 2050, as the aged population increases, it's estimated that there'll be close to 1 million Australians suffering from valvular heart disease. Severe aortic stenosis, for instance, in 2021, there was approximately 100,000 Australians with severe symptomatic aortic stenosis, and that's only going to increase as the population increases. And this is very relevant for your patients because this has a significant impact on patients' mortality and their morbidity. You can see the curve on the left is the famous Braunwald curve on patients with aortic stenosis, which shows that precipitous decline in patient survival once symptoms occur. Similarly, with mitral regurgitation, we see a significant impact on patient survival and rates of heart failure, with the hazards of mortality in most forms of mitral regurgitation in severe disease close to 2. Tricuspid regurgitation has often been ignored and thought of as more of a secondary problem due to left heart disease. But we see now in large echo data sets with long follow-up out to 10 years, significant hazard in patient mortality with severe tricuspid regurgitation. And these graphs on the left here, work by Topolinski et al., which really demonstrated in isolated TR, so patients without left-sided heart disease, but only tricuspid regurgitation, that there was a significant hazard in both mortality and heart failure events. And that was present whether they were symptomatic or asymptomatic. But in the Australian context, aortic stenosis still makes up the primary causes of valve-related death at about 61% of all causes. And the graph down the bottom here is data from the UK, and this really tries to drive the point home of how impactful aortic stenosis is on patient mortality. It's comparing 5-year survival of patients with untreated aortic stenosis to common forms of cancer. And we can see that this 5-year survival is worse than breast cancer, lung cancer, colorectal and ovarian cancer. So it's a significant condition for your patients that certainly needs treatment. And mortality occurs in all these valve-related conditions with a sequential progression of cardiac chamber injury, be it the left ventricle through to the atria and then pulmonary hypertension. And there comes a point where intervention on the valve is futile because there's been such significant structural impact. And so ideally, we're identifying these patients early and we can intervene early to treat them. Now, when do you suspect valvular heart disease? Well, as you all know, a lot of the symptoms, especially early, can be quite subtle. And so it can be quite difficult to tease this out. We often see patients purely describing symptoms of fatigue, especially in tricuspid regurgitation, very vague symptoms, especially early. The classic symptoms of aortic stenosis include exertional dyspnea, chest pain, and syncope or near syncope. And then heart failure symptoms as the disease progresses, both in aortic stenosis, mitral regurgitation, and tricuspid regurgitation, which generally causes more right-sided heart failure symptoms like peripheral edema, pleural effusions, and sometimes ascites as well. Now, what do you do once you start to suspect that the patient might have valvular heart disease? Well, you reach for your stethoscope, like we all do. There's been a bit of debate as to whether the physical exam is even really that helpful in the modern era with the availability of echocardiography. And there's been varying research into this, varying quality. And this is one of the studies that is sort of exemplary of this. This is a UK study. They took 250 asymptomatic patients over the age of 65 who were participating in an echo screening study. And they asked two very brave GPs to be blinded to those results and auscultate the chest to determine if there was a valve lesion. And for patients with significant valvular heart disease, the GPs only displayed a sensitivity of 44% with a specificity of 69%. Now, that might sound not very good, but in the same study, the cardiologists actually didn't do very well either. They only had a sensitivity of 31%, so equally not ideal. And the conclusions were that perhaps this isn't a very useful test, but I would argue the opposite is true. I think this is still very relevant and very useful in your clinical care. But I think what we recognize is that we have to listen to people's hearts more than once because there are many things that can change the audibility of a murmur, specifically the loading conditions, the volume status, the ability to expose and undress the patient, external noise and other distractions. And so just because you didn't hear a murmur 6 months ago doesn't mean you shouldn't listen again because you may pick something up and that can have a significant impact on patient care. And so what do you do once you've identified this? Well, you all know this. The patients undergo a transthoracic echocardiogram. And that certainly is the key modality in identifying and determining the severity of valvular heart disease. But as I'll get into briefly, the determination of these lesions can actually be quite difficult and complex. And we often need to reach for other modalities of imaging, more extensive echo examinations like transesophageal echo or pharmacological stress echo. When we talk about aortic stenosis, the pathway to diagnosis can actually be quite complex. We can recognize high gradient, high flow aortic stenosis relatively easily, but there are other forms that we also see as having the same impact on patient mortality, like low flow, low gradient aortic stenosis and paradoxical low flow, low gradient aortic stenosis. And these patients often need multimodality imaging to assess them and determine the lesion. And it can be very easily missed if you're not suspecting it. The same goes for the regurgitant lesions. We use a mixture of qualitative and quantitative measures to make these diagnoses, and we're often reaching for transesophageal echocardiography, sometimes CMR. So clearly these patients do need to be assessed in an expert setting and ideally in a valve center or a physician who's skilled in the management of valvular heart disease. And it's also because these patients have lesions that can coexist and they can all affect one another. Classically, mitral regurgitation, reducing the apparent severity of aortic stenosis, even in the context of severe lesions, and the reverse being true as well. So now what do you do once you've identified this patient having significant valvular heart disease? What tablets do you reach for? Well, unfortunately, your options are very limited. Diuretics are predominantly the mainstay to manage fluid overload and symptoms of congestion. But even in the context of ventricular functional MR with reduced LV function, we do know that patients do very poorly just with medical therapy alone. Now, surgery used to be the only definitive treatment and the only option for a lot of these patients. But as you see from the data, I've shown that this is a disease of aging, and a lot of patients were too elderly and frail, too comorbid to undergo surgery, and really didn't have any good options. But thankfully, in recent years, there's been an explosion in transcatheter therapies for valvular heart disease. We now have multiple forms of TAVI or transcatheter aortic valve interventions to treat aortic stenosis and even potentially aortic regurgitation in select groups that are now available here at the Canberra Hospital and also National Capital. We have various mitral intervention devices, the repair devices like the MitraClip, which performs mitral edge-to-edge repair, or TEER, and dedicated transcatheter mitral valve replacements that can actually replace a valve without the need for surgery. The tricuspid valve, as I alluded to, is very complex, and there's been quite an explosion in the different devices, from repair devices like clips through to dedicated valve replacements, and also some very unique approaches to valve replacements with cable valve interventions. So I want to talk a bit about aortic stenosis and the transcatheter options for the treatment of this. As you know, I'm talking about TAVI, and many of you are very familiar with what I mean, but essentially what we're doing is we're implanting a valve via a transcatheter approach in the aortic annulus, pushing the native leaflets out of the way. We do that generally by retrograde access via the femoral approach up the aorta, but we can also access the heart from the great vessels in the upper limb or even transapically. And this isn't a new therapy. This has been around now since 2002 as the first implant, and it's been very extensively studied in all subtypes of patients. And I won't labor all this, but this is data from the PARTNER series of trials, which is using the SAPIEN valve. It initially started with PARTNER 1B with the prohibitive risk patients who could not undergo surgery, and we found a significant improvement in patient mortality when they were treated with TAVI. We then studied high surgical risk patients and intermediate surgical risk patients, and we found that there was no hazard in those patients undergoing TAVI, with numerically lower rates of clinical events, including death. And then most recently in low surgical risk patients. So these are your patients in their 70s or well with no comorbidities. And we see that TAVI performs very well in this context with no worsening in mortality with TAVI, but it being numerically lower at 12 months. And this cohort's been studied in other studies, such as the Evolute low risk trial, which is a trial with the Evolute valve, Notion, an early study in this area, again, showing no statistically significant difference. And then Dedicate, which is the more recently published trial out of Germany, which is an investigator-led study, and it actually showed a significant improvement in mortality at just 12 months in patients treated with TAVI who were low surgical risk rather than undergoing surgery. And importantly, we need to know if these valves will last. You're putting these, especially as we're introducing this into lower and lower surgical risk patients who are going to live longer and longer. And the data now for the two major randomized control trials, Evolute low risk and PARTNER 3, certainly shows that the valves are just as durable as surgical valves out to 5 years, with no change in the risk of death or stroke in these patients. And in Evolute low risk, we see that the valves are performing very well with lower gradients than their surgical counterparts and larger valve areas. Similarly, when we look at the PARTNER 3 5-year data, we see, again, no significant difference in terms of biprosthetic valve failure, with very low reintervention rates in TAVI of only just 2% at 5 years. Notion is our longest follow-up. This is out to 10 years, and we see no significant difference in mortality with patients treated with TAVI over surgical valves. But what we do see with TAVI is a significantly lower rate of valve failure and structural valve deterioration, which has a significant impact on your patient's health. Now, this is becoming a safer and safer therapy, and as we look back to data from the US, this is unselected patients from their entire valve registry. So people undergoing TAVI in the US get enrolled in this registry, and we can see that the in-hospital mortality rate is very low for all comers, includes patients in heart failure, cardiogenic shock, etc., under 2%. When we look at major complication rate, again, we see that this remains low. Pacemaker rates is the most common, stubbornly around 10% for all comers treated with TAVI. But other significant complications including vascular injury, stroke, renal injury, paravalvular leak, are very low, in the low single digits. And so TAVI's earned itself a class 1 indication for the treatment of severe tricuspid aortic valve disease in patients over the age of 70. Under the age of 70 who are at low surgical risk, surgery still has a class 1 indication. But any patient in between that, it's important that these patients are assessed in a heart team and determine what is the best therapy for them. We certainly recognize that younger patients with more congenital forms of heart disease, valvular heart disease, benefit from procedures like the Ross procedure, which is certainly a very technically demanding and a highly skilled procedure performed at only a couple of sites in Australia. And then the mechanical valve still does have a role in those in the intermediate age group. But now I don't just use age to determine whether patients should undergo TAVI. The protocoled CT that allows me to examine both the valve anatomy and also their peripheral anatomy allows me to determine whether patients are going to benefit most from TAVI or from surgery. And there are a number of different factors that I look at: calcium distribution, calcium in the left ventricular outflow tract, or a very hostile valve that may benefit better from surgery rather than TAVI, or other issues that may make them more suitable for TAVI. On top of this, as we treat lower and lower risk patients, it's very beholden on an implanter to understand that despite the demonstrated longevity of these valves, they are bioprostheses. And we do know that bioprostheses have a lifespan, and you need to be able to implant a second device within that, especially if your patient is in the younger age group. And so it's very important that you analyze your scan properly to make sure that the patient can accept further devices. This is just a case from a patient I treated when I was working at the Alfred last year. They're actually receiving their third aortic valve. So it was 78. It had a AVR in 2006 that had failed, treated with an Evolut TAVI in 2019 that unfortunately had failed early due to a leaflet tear. And so he's undergoing a third valve and valve procedure with a Sapien TAVI. Now, the issue here is that we had to ensure that we could fit this in regards to ensuring we weren't going to include his coronaries. And that requires a dedicated and very careful analysis of his CT to be able to treat this patient. And this procedure went very well, and he was discharged just the next day. We're also doing TAVI outside of the aortic valve. The Sapien valve allows us to treat failed bioprostheses in the mitral and tricuspid position, which you can see in these two cases on the left. And these patients, both having undergone cardiac surgery previously, would have had a significantly increased and complex surgical procedure, but they were able to be treated with a valve intervention in those failed bioprostheses and were able to be discharged just the following day. Another really important thing that I do get asked, is there an age limit? And look, I would argue no. This is data that I published when I was working at the Alfred, looking at our registry of all the patients we treated, comparing those over the age of 90 to those in their 80s. And we found no clinically significant difference in patient outcomes, except for a slightly higher rate of requiring rehab for patients in their 90s. So in well-selected 90-year-olds, this procedure can be very efficacious. Now, I just want to change gears and talk about mitral intervention and the therapies that are now available and becoming available for patients here in the ACT. So there's two primary approaches to this: repair of the valve and replacement of the valve. Repair is certainly the most studied of the techniques, and that's taken place with the mitral transcatheter edge-to-edge repair, or TEER, mitral TEER, and with the MitraClip or the Pascal device. And what that means is essentially we're restoring coaptation by pulling the leaflets together by implanting clips at the points of regurgitation. And we do that by a transeptal approach from femoral venous access. And this has earned itself in the recent guidelines that were published in 2025, a class 1 indication for patients with ventricular functional MR. So they're patients with heart failure and secondary MR due to that. And that's off the bat of studies such as COAPT and Reshape HF, which showed an almost 40% reduction in patient mortality at 2 years when treated with TEER. In patients with only moderate to severe MR, we see again a 40% reduction in the rate of heart failure hospitalizations. So improving mortality and reducing their heart failure hospitalization. This is a therapy that is significantly beneficial to these patient groups. In patients with primary mitral valve disease, there is an ongoing trial comparing intermediate surgical risk patients with surgical repair to mitral valve repair with TEER. But the largest data comes from the Expand G4 registry published in 2023. This is about over 1,000 patients. And you can see at 1 year, we are achieving almost surgical results with almost 90% of patients having mild or less MR, and over 80% of patients reporting substantial improvements in their symptoms to class 2 or less. So in the context of the evidence that we have at the moment, this has a class 2A indication for patients who are at high surgical risk with primary or degenerative mitral regurgitation. Now, there are a lot of anatomic considerations that go into whether we can repair a valve with an edge-to-edge repair. And there are many higher surgical risk patients who are not anatomically appropriate. And so what do you do in that context? Well, that's where transcatheter mitral valve replacement, or TMVR, certainly is coming into its own. Now, there's a number of devices under research. This is one I'm most familiar with, the HiLife. This is the valve we used in the Alfred. And you can see in their 1 year published data from their feasibility trial, excellent reductions in MR, essentially obliterating mitral regurgitation with similar improvement in patient symptoms. This is some data that I published from the cases we performed at the Alfred. These were patients that we could not repair with clip due to various anatomical constraints. And you can see us preparing this patient to receive this valve implant. It's done by both a retrograde aortic and a venous transeptal approach. We implant a ring to anchor the valve, and then we release the valve from the ventricle back into the atria. And this is done on a patient just under general anesthetic, not on cardiopulmonary bypass. The valve is immediately functional, and they're able to be extubated and go to our CCU and not even require an ICU admission. These patients stayed in hospital for approximately 4 days. There were no major complications, and they had a significant improvement in their patient's symptoms. So a very promising therapy for quite complex patients. And just finally, I just want to show you what's going on in tricuspid regurgitation. As I described earlier, this is complex. Tricuspid is a bit of a misnomer. It's only tricuspid in about 55% of cases. In all other types, it's either quadricuspid, quintucuspid, and rarely bicuspid. The other thing to note is that the coaptation gaps can be very big, and so that does mean that repair with edge-to-edge repair can be difficult. And that's why there are now just a number of devices coming through that are either commercially available or in various forms of research and development. Again, the most studied is the edge-to-edge repair device, also called TriClip, and it involves restoring coaptation by implanting clips, but this time along the coaptation lines between the septal leaflet and the anterior and the posterior leaflet. Now, this was studied in the pivotal Triluminate study, which was randomized TriClip versus medical therapy for patients with at least severe TR. And you can see at 1 year, the results were good. 89% of patients had moderate or less TR. Now, you might question, well, is moderate really good enough? Well, with that, they achieved a significant improvement in patients' quality of life. And we found that patients who achieved moderate or less TR were the ones who found that benefit. And for every grade of TR reduction, the quality of life only increased. With the recently published 2-year data, we find that patients had a almost 50% reduction in heart failure hospitalizations compared to their year prior. And for those who were left with moderate MR or less compared to those with residual severe or greater, whether they're in the device or non-device arm, they had a significant reduction in their heart failure hospitalizations. Now, again, this has a lot of anatomical constraints, and there are a number of patients who are not suitable for TEER for various reasons. And so there are a number of different approaches to replacing the valve or at least dealing with the cable reflux that occurs with TR. So the trick valve here on the right, this is a fluoroscopy of a patient we treated at the Alfred, where we actually implant a valve in the SVC and the IVC, which obliterates the cable reflux and treats the symptoms of TR without actually changing the function of the valve. And we found very good results with this. This is a safe procedure with significant improvement in patient symptoms. There are dedicated TTVR devices which focus on replacing the valve, such as Evoke, which is going through its pivotal study. And it's showing very promising results, essentially obliterating TR, but at the cost of a higher complication rate. So I want to conclude there. I've certainly gone through a lot. And I want to highlight that, importantly, valvular heart disease is common, and it's only going to become more common as our aging population increases. It's certainly a significant cause of morbidity and mortality. Early identification of these patients is crucial, so we can intervene at a point where the heart can remodel and it hasn't sort of gone beyond that point of no return. As GPs, you're very much so on the front line of identifying and treating these patients, and you play a crucial role in valvular heart care. And finally, it's a very exciting time. These devices that I've gone through, we're expanding their indication and their availability in Canberra. Where since I've started just in March, we treating complex TAVI patients, not having to send them to Sydney. We've got a mitral program that's going to be starting in just a couple of weeks, and our tricuspid treatment arm will also be expanding as well. So there's a lot of therapy that's now available to your patients, and I hope this was sort of informative of all that. Thanks so much.
Thanks very much, Liam. Yeah, that was very interesting. Not realizing the burden of valvular heart disease and what we've got to look forward to. Probably I'll get it when I'm older too. Yeah, so we should keep it in mind as doctors and as patients. Okay, I'll hand over to Peter Scott now. Thanks.
Thank you very much for the opportunity to speak this evening. So I'm going to talk on lipid management, focusing more on primary care because new guidelines have been published in 2025 and things are certainly changing in this sphere. New medications are available, and I certainly learned a lot just preparing for this presentation today. So we are actually winning in terms of the fight against heart disease. And I think this is testament to all the changes that have happened in cardiology and also mainly in primary care, actually. So fixing and treating risk factors for heart disease. So compared to 1980, which was close to whenever I was born, the number of patients dying of heart disease has gone from over 400 per 100,000 down to less than 70 in males. So it's a dramatic improvement. And to get it even further, we're sort of in the territory of marginal gains. And sort of Dave Brailsford was famous for his cycling team, trying to find any marginal gain to improve an outcome. And this is sort of where we are now in the primary prevention with lipids, in terms of how can we even get it better to reduce the risk of cardiovascular disease. So Australian guidelines in terms of prevention was published in 2023. And 2 years later, the 2025 guidelines in the ESC have been published. And the 2023 guidelines from Australia are slightly out of date in those 2 years. So they are going to look at trying to do a focus update as well. And there's a bit of debate, even within cardiology at Canberra Hospital, which guidelines should we follow, international guidelines or Australian guidelines? From my point of view, it doesn't matter. You can pick whichever guideline you want. The whole point is they are presented by experts based on the same data. There might be some subtle differences. So even though I might talk about ESC guidelines and then talk about Australian guidelines, it's really up to you which ones you want to follow. And I don't think anyone can criticize you for following an American guideline or a European guideline. And this is the problem because historically, this is what guidelines used to look like, these flowcharts that came out of nowhere, and I cannot interpret that. So they are getting simpler and easier. And I think we're moving away from these multiple steps to try and work out how do we treat patients just to make it simpler, especially in primary prevention. Lipid metabolism is getting more complex as we know more about how lipids form, what's involved in lipidology. There's so many new little subsections of apolipoproteins, I've kind of lost track. So that's why I would just say for general practice, just focus on the LDL. It is definitely one of the most outcome data. It's the one we should target, and I wouldn't really worry too much about the other ones, but we can talk about that later. So why LDL? LDL is the most pro-atherogenic. It is somehow ends up in the vessel wall and leads to inflammation. And inflammation is key for atherosclerosis. The atherosclerotic plaque is then healed, and as part of that healing process, it calcifies. So that's why as we get older with progressive atherosclerosis, there's calcification in the arteries. And it all starts with LDL infiltration into the arteries. And that degree of infiltration is very much dependent on the amount of LDL it's exposed to. So we are moving and shifting slightly from not worrying about high LDL values in young patients to realize that their lifetime risk is increased by that lifetime exposure to LDL, as opposed to looking to 5-year, 10-year outcomes. And it is very clear, and this study is back in 2004, we knew that the lower your LDL, less your cardiovascular outcomes. The better your cardiovascular outcomes, the less cardiac events. And that's in primary and secondary prevention trials. And it's almost linear. So you can see the lower your LDL, and this is American values, so you divide it by 40, that equates to the Australian values of millimoles per liter. So you can see if you get a value of around 1.4 down at the bottom, your risk is almost zero for cardiac events. I don't think we'll ever get to zero, but I honestly think we will get very close to it. So in terms of rule number 1 for cholesterol management, it's really establishing your risk. There are various risk scores. The ESC guidelines quote score 2. So if you see score 2, just think of the Australian Cardiovascular Risk Score calculator. It's actually quite good, quite easy to use. It's online. You can type in the values. So if you hear anything about risk scores, they're all pretty similar. And who to test and how often, according to the Australian guidelines, anyone over the age of 45. If you've got diabetes, age over 35. And if you're First Nations, people should be over the age of 30. And then how often should you do it? I think you should do it more often than every 5 years. But if you're low risk, they say 5 years. If you're intermediate risk, 2 years. But just think about it in your head, especially whenever somebody comes with you with, a blood test that shows a high cholesterol. Start looking at their cardiovascular risk. So the ESA has defined 4 categories of risk: very high, high, moderate, and low. Very high is essentially people with lots of risk factors: severe CKD, familial hypercholesterolemia, severe calcification, or stenoses noted on CTCA. So those are very high risk, and those are the ones that the target for cholesterol is changing to become even lower. High risk patients are classified based on obviously the risk score, but also other risk factors such as diabetes, moderate CKD, marked other risk factors for cardiovascular disease. And interestingly, if your LDL is over 5, then you are classified as high risk, regardless of your age. Just the other day, my sister's best friend had a cholesterol of 5.1, was an LDL of 5.1, and was being told she didn't need a statin. But actually, according to the new guidelines, she is now high risk, and so she should be. And then down to moderate and low risk. And this is the European guidance, what we should be doing when we get that result, depending on their risk. And there's a few things I'm pointing you to. One is in the low risk category, if your LDL is 3 or above, not only do you consider lifestyle, you should consider adding medications such as statins, even if you're low risk, based on the fact it is a lifetime exposure to a high LDL, which is of a concern, especially in low risk patients. And then moving forward, even if you have an LDL of less than 1.8 in very high patients, you still want to consider statins. So it's quite a good sort of a visual diagram, just highlighting that we are getting stricter in how we manage cholesterol and LDL. So what targets do you aim for dependent on their risk? So if you're low risk, you want the cholesterol less than 3 by whatever means. Similarly, if you're moderate risk, you want your cholesterol, sorry, your LDL, let's focus on LDL, you want your LDL less than 2.6. If you're high risk, you want your LDL less than 1.8. If you're very high risk, LDL 1.4. And these are much stricter than the Australian guidelines of 2023 in terms of targets. And again, this is primary prevention. The ESC do mention extreme risk. I don't think you really need to worry about extreme risk. These sort of patients are the ones that Liam and I see. These are the patients who keep coming in with recurrent stent stenosis, recurrent chest pains, recurring events. So they are classifying these extreme risk patients, even aiming an LDL of less than 1, which is nigh on impossible to get. The other thing people talk about currently is lipoprotein little a. 2 or 3 years ago, I'd barely heard of it. Now everyone's talking about it. And lipoprotein little a is a very similar particle to LDL. The difference being it is predominantly genetic. So it's not influenced by diet. And we're sort of noticing it being elevated in the young patients who come in with heart attacks and their cholesterols aren't too bad and they don't have blood pressure and they're not diabetic. No one really understands the physiological function particularly well, but it's obviously very pro-atherogenic. To confuse things even more, it's got 2 units, so milligrams per deciliter and nanomoles per liter, and I think different labs in Australia do different things. So just look at the normal values whenever you get the result. If it is slightly up, so above 50, if it is elevated and it's above 50, then that increases your risk. If it's significantly increased above 100, then that puts you at very high risk. The ESC recognize its importance to the point where they say every single patient that you see that is looking to get a cardiovascular risk assessment, you should do a lipoprotein little a on. And the risk, if above 100, is similar to familial hypercholesterolemia. At the moment, it is not Medicare rebatable, but I think the cost is about $150. The reason I don't know the cost is because I still haven't had mine done, and I'm over the age of 45, and maybe I should do that. I'll put it on the list of things I need to do. If it's sort of in between, what they suggest is your risk can change up. So if you're low risk, but you get a lipoprotein little a that's mildly elevated, you're then medium risk. And if you're medium risk, you go to high risk. But if it's over 100, then you treat as high risk. And in terms of what you do whenever you have an elevated lipoprotein little a, there's no target treatment for that yet. But it advocates very, very strict cholesterol management. So focusing on LDL targets aligned with what the previous slide showed. So 1.4, 1.8, dependent on your risk. And this is why. So the graph on the left just shows what the normal values are in the population. So most people have a value less than 50, but those that have values over 50 have a dramatic increase in their cardiovascular events. Some people have extremely high lipoprotein little a levels are at extremely high risk. Coronary calcium. This is a big topic. It's a test that's very easy to do. It's very limited radiation. It's very quick and easy. But is it indicated? Does it really change your management? It is now being mentioned in guidelines. The ones they recommend you should do a calcium score if you feel it's indicated is in the intermediate risk. Predominantly those you're worried about determining whether you should go on statins or not. If it is 0, you could possibly reduce their risk from intermediate down to low risk. If it's a score of 100, and again, this is all dependent on age, but the guidelines are trying to pick a number, and 100 seems to be the one that they're going for. They're going to say it's defined as high risk. If it's over 1,000, treat as very high risk. If it's in between 1 and 100, you could increase the risk level. It's not particularly helpful, but it's sort of on an individual case-by-case discussion with the patient to say that they do have atherosclerosis. So maybe it may be an indicator to be a bit more aggressive. It's not really that validated for younger patients because they tend to have soft plaque. So it doesn't really rule out exactly in this sort of cohort. If you do a calcium score and then a CTCA, if you do notice they've got obstructive coronary disease, so severe stenosis greater than 50%, that is now treated as very high risk according to the guidelines. This is the Australian guideline from 2023 talking about calcium scoring. Again, they say low risk, don't really do it unless you're very worried about them. If it's high risk, don't do it because it's not going to change management. They're going to have a high calcium score. If they're moderate, then you can do, and that's quite similar to the ESC guidelines, and then the values are quite similar. In terms of who else to screen, they strongly recommend not to population screen everybody. Don't screen people who are high risk. Don't do a calcium score for people who have known cardiovascular disease. It's not going to change your management for them. It could be considered in patients who have low risk with possible additional risk factors or intermediate risk to possibly change their risk category. I wouldn't consider the final point there where it says if it's 0, consider retesting in 2 to 5 years. I think it's a good test at the start if you are going to do it, but I'm not convinced it's worthwhile doing a calcium score every 2 to 5 years. And again, the reason is to change whether you go from moderate to high risk, therefore your target goals for LDL change. So what do we do with low risk patients? Lifestyle. And I'll talk a little bit about diet and things like that. Exercise. I don't think there's much evidence to say what exercise, but regular, sustained exercise is very important. The ESC guidelines, not the Australian guidelines, are now stipulating that if they're not hitting LDL of less than 3 despite lifestyle, consider a statin. Similarly, if you've got additional risk factors, consider a calcium score. One thing I do for younger patients with elevated LDL that are not particularly enamored with going on statins, I sort of say to them, well, why don't you go on to a statin for maybe 3 or 6 months and then come off it? Because in that 3 to 6 months, you'll get your LDL down to 2 or 1.8. And then if you come off it, then you can sort of try lifestyle a little bit and not worry about taking so long to get to that level. See if you can hold it. It's often easier to hold your cholesterol with lifestyle and dietary changes rather than gradually reducing it. And in terms of other risk factors, they mention there's a whole range, but if you've got a strong family history, high ethnicity group, lots of stress, social deprivation, physical inactivity, obesity, those are sort of additional factors that for a low risk patient, whenever you put in the score, you might want to consider additional testing such as calcium scoring, or you may want to consider being a bit more aggressive in terms of how you treat them. And then obviously the lipoprotein little a. And this is similar in the Australian guidelines, but they also mention obviously Aboriginal and Torres Strait Islander people consider that as an additional risk factor. Moderate risk, if we look at the table, initiate statins similarly if not hitting targets, and especially considering calcium scoring with additional risk factors to possibly push it up to higher risk. And the target for moderate is sort of aiming for an LDL of less than 2.6 by whatever means. Triglycerides are the forgotten lipids, and there's a reason for that. A lot of trials have failed to show any outcome benefit for aggressive triglycerides, except for one thing, and that one thing is for hypertriglyceridemia of extreme levels that lead to pancreatitis. So you're treating those extreme high levels, and I've seen patients where you take blood from them, and it's literally, it's like the roast Sunday dinner where you just see a list like 2 centimeters worth of fat congealing with blood below it. And that's a very high risk factor for pancreatitis, which can lead to death. So triglyceridemia, where it's extreme, definitely can lead to pancreatitis and can lead to death. But targeting triglycerides as a means for primary prevention has had very poor results. And that is why both guidelines stipulate your first line of treatment for triglyceridemia, high triglyceride levels, is a statin. So it's to get your LDL down, which also will consequently get your triglycerides down. If they're still significantly elevated and patients are high or very high risk, The European guidelines recommend Vazkepa, which is a new medication. Basically, it's omega-3 polyunsaturated fatty acids, and they have been shown in one trial to reduce MACE. Fenofibrates, interestingly, are not as evidence-based, but they are cheap, effective at getting your triglycerides down, so they're still in current Australian guidelines. And newer therapies are on the way. Valvular, which I can't say, is a dramatic treatment for triglycerides, mainly for patients where we're worried about pancreatitis, who get admitted with really high levels. So what is the diet that we recommend? The only one with evidence is the Mediterranean diet. It does reduce MACE in a meta-analysis where they've studied the Mediterranean diet. It's just very difficult to study diet because unless you're in a prison situation, you can't really truly see what people are eating and doing. But the Mediterranean diet does seem to fit with what we sort of think as common sense as being healthy, namely lots of vegetables, whole grains, legumes, seeds, beans, bit of fish, less meat, less dairy, and certainly less sweets, moderate alcohol. This is a really good study just published a year ago or a year or two ago, and they did randomized trial looking at a number of supplements, comparing it to 5 milligrams of rosuvastatin. So they looked at cinnamon, garlic, fish oil, turmeric, plant sterols, and red yeast rice. And they measured cholesterol LDL levels. And it was quite clear that none of them reduced LDL except for the rosuvastatin 5 milligrams. So that's why in the guidelines, it's recommended as a class 3, don't do. It could cause harm. There's no evidence for it, which is pretty as much as strong as they could say not to think about supplements if you're trying to treat LDL. What other statin alternatives are there, especially for those who cannot take statins? There's a new drug called bempedoic acid, which has been clinically proven to dramatically reduce LDL. It works in a different way than statins. It does not cause the muscle discomfort that statins seem to do. The big risk with it is gout because it increases uric acid, but it's not yet available in Australia. It is available in Europe and America. And this is a very nice sort of summary slide of the effect statins and other medications have on LDL. So you can see how a high-intensity statin with EZE, which is ezetimibe, can get 60% reduction, and adding in bempedoic acid can reduce to 70%, and then the max is obviously the PCSK9 inhibitors, which are the injectable therapy for cholesterol that you can give every 2 weeks or every 6 months, depending on the product. This isn't a fault in my slide. This is the PBS criteria for prescribing PCSK9 inhibitors in primary prevention. It is almost impossible. You have to have lots of risk factors for cardiovascular disease, evidence of coronary disease, and obviously having evidence of not able to take statins. So it's difficult, it's not impossible, but in the PBS, they do have quite a lot of restrictions for PCSK9 inhibitors. However, they are very effective. They have very few side effects. And obviously we all have patients who are on them with success. So what do they recommend? This is actually from the NHS website for patients who are statin sensitive. Some recommendations is for the longer lasting statins like atorvastatin, rosuvastatin, giving it twice a week as opposed to every day for those who are very sensitive in terms of side effects. You can discuss about a statin holiday, so maybe do a week on or a week off. As I mentioned before, about 6 months of the medication, then stop and pushing lifestyle. And even different brand names can be enough that people go, oh, I can take this brand name, I can't take this other one. Interestingly, they looked at all the side effects in the randomized controlled trials for statins. And in number A, which is the one whenever they were blinded. If you look at muscle-related side effects with statins, they were the same as placebo. But as soon as they were told and unblinded, as in number B, people started to develop side effects, which is, I think, is quite interesting. Renal impairment, if you've got normal renal function, the risk calculator works well. But if you've got any evidence of impaired kidney function, your risk does increase quite dramatically. So if your GFR is less than 45, you're deemed high risk. And how have things changed? So these are the guidelines from 2002 from New Zealand. And the LDL was aiming for a target of less than 2.5 in those that were high risk. So we have got much stricter in terms of what our targets are. So why does this all happen? I mean, what is going on with our LDL and what is going on with our cholesterol? And again, this is from 2004 from data where they measured people's cholesterol levels from hunter-gatherer Inuit populations and compared it to primates and mammals, and then obviously the modern Western American. And you can see that the cholesterol level should be sitting at around 2.8 if you look at the average for a human being, even less if you're a mammal. So you can see that fits with an LDL of close to 1.4, 1.5. So that's why our targets, I think, are pushing towards what it naturally should sit at. There's also a good trial looking at, I think it's Inuits from Greenland, where they were able to show geographically how close they were to Western civilization was directly correlated with their LDL levels. So despite, you know, the high fat protein diet of what the Inuits were eating in Canada or Greenland, whatever it was. But you can see that there is something to do with the Western diet that is pushing up our total cholesterol. So last couple of slides, the recommendations is that basically people should be getting cardiovascular risk scoring. Use calcium scoring sparingly, but mainly in the intermediate group. Don't do it in people who are high risk. Don't really do it in people who are low risk unless you're very much concerned. Think about a lipoprotein(a) and then the targets have changed. So my learning points from this is guideline targets of LDL are getting lower. And I think the future guideline of 2030, I'm very positive is going to be you're either low risk or you're high risk. And if you're high risk, your LDL is going to be 1.8. Just get there by whatever means. Even low-risk patients from the ESC guidelines, they can take statins to get their LDL less than 3. Calcium scoring, which is something I've always been quite wary of, probably does have an indication nowadays for moderate-risk patients to push them up to higher risk. And then lipoprotein(a) is important, and we should really consider about doing it more. Okay, so thanks very much.
That was a little bit depressing, Peter. Those targets, yeah, they're dropping, aren't they? While you were doing your talk, I went on to the score too and did my cardiovascular risk. And it said that I had a 1.9% in 10-year risk, but my cholesterol is definitely not hitting targets. So that's kind of interesting that it didn't give me a high risk score. Peter?
Yeah, so
it seems like the blood pressure really kind of lowers things for you.
Probably age is a big thing. So I don't know what. So you came out then at low risk.
Yeah, I came out as low risk, but
I don't
my
know
cholesterol would be kind of jumping up and down. And
actually, even at low risk, this is what the ESC guidelines are now saying. If you're not getting it less than 3, your LDL, then you really need to consider therapy if you can't get it down to lifestyle. And that's not what the Australian guidelines said in 2023. So it has changed. It's getting more aggressive. So even though you're low risk, which is good, and you know, in all fairness, you're not the sort of people that we see coming in with heart attacks. You know, it's you know the person who's going to have a heart attack whenever you see them, and so you'd be low risk, but you still can't forget about it. Whereas, I would strongly suggest that the guidelines are sort of highlighting the people who are low risk, and we are going to start treating them.
Because certainly the majority of people we see in general practice, and we usually do the CBD risk calculator because it's integrated into our practice software. They often do come out as low risk, but they've all got these cholesterol levels of 5.8, 6.1, an LDL of 4.1. So that's kind of a pretty typical conversation that we have with people, and we're not starting statins, but maybe we should be, because in the old guidelines you had to have a total cholesterol of greater than 7.5 or have tried kind of a high cholesterol and tried lifestyle for 3 months. So, we were holding back on starting statins, but we need to kind of change our mindset now, it sounds like.
Yeah, without a doubt. I mean, it's like blood pressure. You don't sit with somebody with a blood pressure of 145/80 until for the next 5 years.
Yeah.
You treat it. And I've always been saying this since I started being a cardiologist, is that why do we do all these risk scores and risk analysis to consider treating cholesterol? And I think this is where the guidelines are going. But it doesn't mean you should start it on everybody. If you are young, you have time. So if you're young and low risk, lifestyle is still the first thing they should try, unless their LDL is greater than 5. And then they are high risk. And if they are high risk, they should go on statins. So
what about you talked about the Mediterranean diet, you talked about supplements. Is there a role for soluble fiber and for beta glucan? Not really. So they're in the same category as fish oil and turmeric.
If you want to if you own a supplementation shop and you want to sell these things, there's no evidence. No evidence.
Right.
So fiber is good if you're having a high fiber diet is good to reduce your risk of colon cancer. So,
but in terms of it binding cholesterol and helping to excrete it, doesn't have any evidence.
Sorry.
Taking everything away, including the cheese. What about these new medications? So are they very expensive?
So PCSK9 inhibitors are very expensive, and that's why they are very restricted. And the bempedoic acid isn't available in Australia yet, so I can't comment how much it's going to cost. But I would envisage it being cheaper than the PCSK9 inhibitors.
Yeah. And the Vescaper?
Oh, I don't know how much that is actually, but again, if it's it is on the PBS, so it'll say there how much it is, but I presume it's subsidized if you fulfill the criteria.
You have to fill the criteria. What about things like Wegovy? We're seeing in GP land that people's cholesterol does drop when they start Wegovy.
Yeah, that's true. Yeah, definitely. Obviously, it's
semaglutide. Sorry.
Yeah. Any brand will do. I think yes, it definitely does, but it never will be a therapy for cholesterol, if that makes sense.
Yeah.
So
because the statins work too well.
Statins work too well, but also it is for an alternate purpose. So I don't think it'll ever come in as a primary treatment for cholesterol.
Yeah, it's a good byproduct.
Correct. It's a nice side effect for patients who have the indication for diabetes and weight loss. And a good byproduct is going to be getting the cholesterol down a little bit. For those who are statin naive and are obese and are diabetic, statin intolerant, I should say, it's going to be a good treatment. And I have seen it as well where it has worked. Yeah.
So, and going back to the lipoprotein A, so we're going to get onto you soon, Liam, but I'm just having my go with Peter. With the lipoprotein A, if someone has low cholesterol, but they've got an elevated lipoprotein A, like 75 or over 100, would you go for a coronary? That would be an indication for a CAC?
So, yeah, I mean, so again, it goes to what their risk is initially, but already they've been moved up from low, if they're low risk, up to medium. If it's above 100, that's now high risk. So high risk is actually where they're saying you shouldn't do calcium scores.
Yeah, so it's more the 75s.
So if it's 75, then yeah, maybe that would be a good one to be moderate risk to see what but the cholesterol level you're targeting now is then getting much into the realms of 1.8 in LDL, which is very difficult to get there without statins. But certainly whenever I eventually do get my lipoprotein little a, I think it is in any way elevated.
So can I ask you an inappropriate and probably overstepping the mark. Would you say that most cardiologists who've done their cholesterol and they found out they've got a LDL of greater than 3 would take a statin? That would be a possible. Yep. Okay, so we should just do what the cardiologists do.
Well, this is what I say to patients, actually. I say
Yeah.
the one tablet a cardiologist would take would be a statin.
Yep. Right.
Those that aren't keen, I say, like, your GP thinks it's a good idea, and the one
Mm.
tablet a cardiologist would take.
Yeah, people are very reluctant to start statins in GP
Yeah.
land, and I think it's all to do with all the kind of statin myositis, muscle aches, and the media it gets, and I had cognitive impairment after I started my statin, but
Yeah.
in fact, there's evidence saying that it's really good for preventing dementia and Alzheimer's. So, yeah,
Every single patient, I worked on a psychogeriatric board, and
Mm.
every single patient was on statins.
Yeah,
That's not causation, it's an association, because
Yeah.
of cardiovascular disease and has led to multi-infarct dementia.
yeah. Okay, thank you very much. So I'll just a few questions for you, Liam. So the transcatheter valvular interventions, they sound quite revolutionary, and I was just wondering, how long do they take? How many can you do in a day, and how much do they cost?
Oh yeah. Say for a TAVI, usually takes us about an hour to do a TAVI. So, when you're running through just one cath lab, the most I've ever done is 6 in a day, but that's quite a lot of work. That's quite hard work. So usually we're getting through about sort of 4 a day on a more reasonable list. The mitral edge-to-edge repairs do take a lot longer, so that's sort of a 2 to 3 hour procedure, and 2 to 3 a day. 3 is a very long day. So yeah, look, that's the procedures. In terms of cost, for a patient, the cost in the public system is obviously zero. And different companies sell these devices for different values, but the cost to the health system is less than patients undergoing cardiac surgery for these conditions. So it's certainly, in terms of the recovery time, is much quicker. The need for ICU beds is almost non-existent, and patients spend a lot less time in hospital. So it's certainly a cost-effective therapy for a challenging condition. Oh, sorry, you're muted.
Yeah, sorry about that. We never really I haven't seen many people referred for this, and I imagine it's something that the cardiologist would refer rather than the GP. So
Yeah.
we often get echo reports saying trace, mild, moderate regurgitation,
Yeah.
but we never actually see the next step of people being referred for them. Is that just it's such a new intervention that it hasn't happened, or is it something
look,
that doesn't happen in Canberra, or?
I think the referral pathway for any valve intervention is coming from a cardiologist. That the patient may be referred directly to a cardiologist who does those valvular interventions. That certainly can come from a GP if you have an echo report that says severe or moderate to severe, whatever the lesion may be. So that pathway certainly can exist. In general, when patients are cared for by cardiologists and they do detect these lesions, they are either referring them to surgeons or they're potentially referring them to cardiologists who can perform these transcatheter interventions. I will say that what we do utilize for all of our patients in this context is the MDT, or the multidisciplinary meeting, where we discuss all these cases. We discuss them with other cardiologists, surgeons, and it's a very holistic approach in terms of how we treat these patients, which direction they go, what we think is best. So it's sort of stepwise, but the whole referral process can very much so start from the GP, especially if you've had an echo already performed.
Yeah. And what about following up those people with the mild mitral regurg or the trace? Because that would be the majority of echo reports we get, that everyone's got a little bit of something.
Yeah, that's correct. And like, as you echo the older population, you're certainly going to see that more and more frequently. These patients, especially trace is almost a description that the valve is normal, especially for trace regurgitation in the tricuspid space, very much so, almost normal. And again, so with the mitral valve. If I saw that, I'd think about potentially at most repeating it within 5 years. In terms of mild disease, depending on the nature of the regurgitation, again, you're thinking you're going to repeat probably in 3 to 5 years. But there are certain other associated conditions that might prompt you to want to repeat that echo sooner. And obviously, if then symptoms were to develop, it would suggest that something has changed.
Go quicker. Yep.
Yeah.
And what about when people have had them? Do they still need to be on anticoagulants afterwards? Do they need to be on antibiotics for dental procedures?
Yeah, so look, in general, so if we're talking about valve replacements with TAVI, then yes, antibiotics, yes, for dental procedures, like you would with other surgical prosthetic valves. In terms of anticoagulation, our understanding of this space has evolved, and when now the evidence would suggest we just use a single agent. So if they've got an indication to be anticoagulated, like atrial fibrillation, so warfarin or a NOAC is reasonable, whichever agent is most appropriate for the patient. If they don't have an indication for a NOAC, then we just use a single antiplatelet, and that can be aspirin, or in some cases, if the patient's already on clopidogrel for another reason, we continue that.
Right. Yep. No, that's easy. And yeah, we had a talk earlier about stopping them for skin excisions or whatever, or surgery. And with the single antiplatelet agent, you don't need to stop them.
Oh, sorry, I think I might have lost you just there.
Yeah,
no,
yeah.
So you're saying
That was
that's something.
We often get questions about whether to stop for a surgical procedure or the antiplatelet agent, but if it's a single one, we don't stop.
Yeah, that's correct. The valve thrombosis risk with these, because they're bioprostheses, is in the short term is very, very low. So, like we're talking TAVI, if you had to withhold a NOAC that they're on for atrial fibrillation, then you don't need to be specifically concerned about the TAVI as an issue. But obviously, it just needs to be restarted when it can be in the future. Yep.
Okay, that was very, very interesting. And yeah, so Liam, cause for looking out for more valvular heart disease and being a bit more proactive about referring people for TAVI. And Peter, cholesterol targets and things like that. Yep. So that's going to change what we do. So thank you very much for both of you for updating us. I'm sure our audience really appreciates it. And just want to say how much we appreciate it as well at Capital Health Network. Just to let people know that we will be putting this webinar up on the YouTube page, the Capital Health Network YouTube page, if you'd like to watch it, or if you want to send it to friends, because obviously we like to know when things change in the primary care space. And certainly, from the talk tonight, we know they have, and it's important for us to keep up to date with this information. Please feel free to self-report 1.5 hours of educational activities to your CPD home, and also fill in the evaluation survey for us. And yeah, just thank you very much to the speakers again, and we'll say good night. Thanks.
Thanks, everyone.
Yeah, bye.